Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today we are jumping right into Heart Month, and we're going to be talking about paving the way forward, clinical trials in cardiac care. I have Dr. Adriana Olivares with me. She is with our TMC Cardiovascular Clinical Research Department. I bet a lot of people didn't even know that we had this department. So I'm sure Dr. Olivares will share more about that as well. I think it's great that right here within TMC, you can learn all the things that you need to, all about your cardiovascular needs. How are you today, Dr. Olivares?
I'm doing well, Maya. How are you? How's everyone
Good.
doing?
Thank you. So you have an online audience watching from home along with an in-person audience. If you're watching from home and if you've got any questions that come up during the presentation, please feel free to add those to the chat and we will get those answered after your presentation. I'm going to go ahead and I will add that up for you so that you can go ahead and get started.
Perfect. Thank you so much. And thank you everyone for being here. Like Maya said, I'm Dr. Olivares or Dr. O. That's how I'm really known at the office. Sometimes I say if patients ask for my full real last name, no one really knows who I am. So Dr. O for most of my patients. And I work with the clinical research department. And today I'm going to be focusing on our cardiovascular research program that we do have, which is quite extensive. And I'm very excited to be here. Like Maya said, sometimes not a lot of people know we have this department, with TMC Health. So I'm really happy to talk to you about all the trials we do and why we do them and what are the indications for them. So thank you so much for having me. I'd like to start off here with our team, who we work with most closely together. So we have Dr. Wagner, who's the medical director of cardiac research. We have Natalia Elias-Calles, who's our director of clinical research. She runs the entire program. And then you have myself, Dr. Olivares. I'm the clinical research investigator as well as the research fellow. So that's why you see my name on here twice. I'm doing kind of a hybrid. My official graduation is in June of this year, but I started the new role a little bit early on here. And we have our team here is composed of another research fellow as well. We have an engineering research fellowship program, so postdoctoral. And it's really important. We think engineers develop all these devices we work with. So it's really important to be able to for them to learn about it and see kind of the other side of it, how we run those trials once those devices are created. Our team's composed of a biostatistician, we have a manager, clinical research coordinators, as well as clinical research assistants. And we're located right on the south side of Grant as well. Perfect. So we have our list of active studies here, and we have kind of how I broke it up was by pathology or disease, what the indication is, the patients who have these and what they could benefit from, the clinical trial or study name, as well as the device, the name of the device that we're working with here. And one thing I like to mention to kind of all the patients that come into our office is, why do we have clinical trials? Sometimes there's the obvious reason to expand medical, indications. Everything we have available today came about because of a trial that happened early on. And, we gave that data, was tested, tried and true, and now it's commercially available. And so that's why we continue to do that, continue to create new devices for patients who might not otherwise have an option. But also for sometimes, there's something already available out there and someone can wonder, why don't we have another option? Why are they trying to make more of these if we have one that works already? And I think it's really important to know just that, we're not all the same. We all know my heart is different from your heart and it's different from your heart. So that one device might not work for all of us. So that's why it's really important that even so sometimes we do have commercially available options or options that have already been FDA approved. It's really important to keep creating more devices so that we can ensure everyone will have an option one day to treat them. Perfect. And I added a little glossary in here just because, sometimes these words that we use in the clinical research world are not words that we use every day. They can be a little bit different. So I like to just briefly go over them so that you have it on there as we continue the presentation. You can refer back to them as well. So something you'll hear me say very often today is participant or subject. So a person or volunteer who volunteers to take part in a clinical study or trial. Essentially all the patients that come through our office. Prospective trial follows a group of people over time to observe how they develop. So someone we meet today and we continue to watch them and observe them into the future as time progresses. A retrospective trial analyzes data from patients who have already been diagnosed with a condition or disease or already have undergone a treatment. So someone we meet today and we look at everything that went on kind of before that time period. A post-market trial conducted after a drug or device has received regulatory approval to gather long-term data on the safety, efficacy, and overall performance of the product. So something that's already been tested, FDA approved, but we just want to gather more data on how patients respond to this. A blinded study, a study in which participants don't know which treatment they are receiving. Unblinded, participants are aware of which treatment they are receiving. A control group, participants who do not receive the treatment being studied in the trial, but instead receive the standard of care treatment or placebo. Randomized, compares the effects of different treatments on a group of people, includes a control group, and are the most reliable way of conducting research too. So that's another one you'll hear me say a lot today, randomized. And non-randomized or single arm, all participants receive the treatment being studied and there is no control group. Multi-center, a study that involves multiple medical institutions that enroll and follow participants, so not just one hospital, not just TMC, but multiple hospitals across the country or the world sometimes. And GDMT, guideline-directed medical therapy. So that's kind of patients who are on the best medication out there for their condition and their specific pathology or disease. So you'll keep that on there, and you need to refer back. It's on there for your reference. And then this is just an example of how our slides are going to be formatted today, just so it's a little bit clear. We'll have the clinical trial or study name at the top. And then at the bottom of that, you'll see the investigator's name. So these are the physicians at our hospital or our institution who are actively involved in the trials themselves. And then in those four kind of slides or bars that show up here, we have the study design, how the clinical trial is set up, whether it's retrospective or prospective, different treatment groups or cohorts, single or multiple hospitals participating, and kind of a brief description of the goal. Patient population, who could we possibly suggest this as an option? Who could potentially benefit from this study? The primary endpoints, what is the clinical trial study additionally trying to review, assess, or prove? And study enrollment goal, so the number of hospitals participating in this study, as well as the number of patients who we're looking to enroll in this studies. There we go. Perfect. So I think it's really important, if we're going to talk about this today, that you know what we're talking about. So getting to know your heart. So we have a picture on here, and I also like to use kind of just a little model here as well. This is what I use in office all the time. So I always tell my patients, if you were to split me down the middle and look straight into my chest, this is what you would see. We'd have the right side of the heart, left side of the heart, top half, and bottom half, right? And then I like this picture right here because it's already kind of color-coded. You have the right side of the heart as being blue and the left side of the heart being red, meaning the right side or the blue side receives all the deoxygenated blood from the body, all that blood that's coming into the heart, and the left side or the red part of the heart is all the oxygenated blood that's going to be pumped out to the aorta and eventually our entire body. I like to think of the aorta, which is kind of the final stop, as the freeway that sends blood to our entire body, head, gut, toes, and everything in between. So that's kind of the big basis of our hearts: right side, left side, top half, and bottom half. And now here in this model, we drew, I can't take credit for that. That was our previous research investigator who drew this little black line on here, which is something really important that model in there was missing that this one has. It's called the left atrial appendage, something that the majority of the population has. About 99% of the population has this. It's very rare that someone would be born without it. However, it's missing from a lot of important heart models. And for the first kind of disease that we're going to talk about, it's something that's really important. So atrial fibrillation. Normally our heart, when it beats, it's supposed to kind of beat like this. Normal, what a doctor will call normal sinus rhythm, right? It's constant, same beat, pretty equal. When someone has AFib, essentially it's an irregular heart rhythm. So that first heart you'll see here, the typical heart rhythm, our heart kind of generates its own electricity as it's beating. When someone has AFib, we like to say that top part of the heart is kind of dancing to the beat of its own drum, has a mind of its own, which is something generates a little bit of chaos in that electricity. And for patients who can feel AFib, not all patients notice when they are in AFib, but for patients who do, it can cause a lot of problems. They can feel the palpitations. They can feel short of breath. It can be pretty debilitating when someone does feel their AFib. And then that left atrial appendage, that's that top left pocket here in our heart that comes up the top portion of the heart. The reason I say it's really important in patients who have AFib, it's because it's not really hollow like you see it in this model. It is composed kind of tissue and muscular fibers in there. So as we come in and out of AFib, the risk is that blood can get caught in that left atrial appendage, linger for a little too long, form a clot, and that clot can migrate from that left atrial appendage into the top left room of the heart, migrate into the bottom left room, and from this room comes off the aorta. Like I said, that's the freeway that sends blood to our entire body, head, gut, toes, and everything in between. And the first exits that come off that freeway go straight to the brain. So there's an increased risk in patients who have AFib of having a stroke when those clots can form. And on that second picture on here, it actually shows the site of clot formation within the left atrial appendage. So when someone gets diagnosed with AFib, the first things that your doctor, your cardiologist, your primary care, whoever it may be, will put you on a blood thinner. That's usually one of the first things they'll do because it's really important to prevent those clots from forming or to dissolve them if they've already formed. Now, sometimes patients can't tolerate those blood thinners. Sometimes we put them on them, but they can have GI bleeds. They can have severe nosebleeds. Or if they have kind of a balance issue, having a fall can be very dangerous because we always say that blood thinner doesn't just thin the blood in our hearts, it thins the blood in our brain, in our gut, in our toes, and everything in between. So it can cause a lot of problems. And for those patients who can't tolerate a blood thinner, we come into this area of what do? We need them to kind of be on some form of therapy in order to prevent clots from forming and reduce the risk of strokes, but they can't be on the medication. So a device was developed and a procedure called the left atrial appendage closure procedure, which essentially is kind of like putting a cork in a bottle, trying to block off that left atrial appendage, putting something in here to prevent blood from going in. And preventing blood from going in, thus reducing the risk of blood getting in there, clots forming, and reducing the risk of strokes. And at that point, it's considered safe to take a patient off their blood thinner if everything looks good. Now, for that, you may have heard seen commercials for the Watchman device that Boston Scientific makes, or the Amulet device that Abbott makes. So those are two devices that have already been approved, available on the market to treat patients with this condition, with AFib, who can't tolerate a blood thinner. The next two slides that I'm going to talk to you about deal with what I was talking about in the beginning, creating more devices that can help treat these conditions as well. So the first study I'll talk about is called the CONFORM study. You'll see the investigators on there. I won't read them out every time, but they're in there for your reference. And this study is a prospective, from today into the future, randomized 1-to-1. So 50% of patients will receive one treatment, 50% of the patients will receive another treatment. Multi-center study, so not just TMC, but multiple hospitals. And it's looking to evaluate the safety and efficacy of the conformal class device by demonstrating non-inferiority to currently available left atrial appendage closure devices out there. So I actually have the CONFORM device here with me, and I'll show it to you. So it's kind of spongy. Show it on the camera as well so people can see it. And this device serves the same purpose as those devices already available, as the Watchman and the Amulet, but the material is different. Its composition is a little bit different, and the way it works, it's supposed to conform, as it's proper name, to that appendage. So like I said, that left atrial appendage has different sizes and it looks different in everyone. So if the goal of this device, it's supposed to accommodate maybe potentially a little better to that left atrial appendage. So the population that's being studied is non-valvular atrial fibrillation in subjects with an increased risk for ischemic stroke or systemic embolism that are unable to tolerate long-term anticoagulation. So unable to tolerate that blood thinner for a long time. And the primary endpoints are major procedure-related complications within 12 months and deemed procedure-related complications, as well as ischemic stroke and systemic embolism through 18 months. And the study enrollment goals are 100 hospitals are participating in 100 sites, and they're looking to enroll 1,900 subjects. So this is really the study is looking to compare this device to the already commercially approved therapies. And I have another picture of it on there as well. This next study is the laminar study, which again, same idea. It's looking to close off that left atrial appendage in subjects who can't tolerate that blood thinner, but it's a pretty small device. It might be even hard to think. There it is. It's on the picture. It's a little bit small. I have it on here so you guys can look at it afterwards in the kind of a 3D-printed heart model that we have. But essentially the idea of this device, it's like a whisk that you use to make eggs. So before you're born, as your heart's developing, all your body parts are developing, that left atrial appendage is also being developed, and it's growing in a clockwise way. So it's going clockwise, and the idea of this device is that it'll grab onto the tissue and turn that tissue counterclockwise, so kind of closing it from the inside, rather than the other ones which are stopping kind of like a cork. This one's trying to close it off from the inside. So the study design for this device is a prospective, same thing, randomized 1-to-1, multi-center study evaluating safety, efficacy of the laminar system to currently available left atrial appendage closure devices out there. So it's also comparing it to what's already out there in the market. Patient population, similarly, non-valvular atrial fibrillation in subjects with increased risk for ischemic stroke or systemic embolism that are unable to tolerate long-term oral anticoagulation. Primary endpoints, composite rate of all-cause mortality, major bleeding, pericardial effusion requiring drainage, device embolization, and device or procedure-related events requiring intervention at 12 months. Study enrollment is 100 sites, and are looking to enroll 1,500 subjects. Perfect. Now we're going to shift a little bit away from atrial fibrillation and talk about our valves and the valves in our hearts. That's why we have that model again, and I'll bring this one up again with me. So we'll go back to you splitting me down the middle and looking straight into my chest. We talked about the right side of the heart, left side of the heart, top half, and bottom half. Now, these 4 areas in our hearts, which are also, you can also see in there, but these 4 areas in our hearts, we like to think of essentially as rooms. And just like to come into this room, we had to get through that door. Same thing happens in our heart. Our blood has to go through some doors, which essentially are our valves. So you'll see the valves label on this model. We have the pulmonic valve, the tricuspid valve, the aortic valve, and the mitral valve. And today I'll be talking about 3 of those, the tricuspid, the aortic, and the mitral valve. You might be wondering why I have those doors there opening and closing. And I think, sometimes when you go to the doctor, you get that ultrasound of the heart from the outside of those echoes. You might hear that someone has, or that you have a leaky valve, or that you have a tight valve, stenotic valve. What do those things really mean? So I think for me, this is the simplest way of explaining. If we all pretend that we're, let's say, in the bottom left room of the heart, what normally happens, and it's the same way regardless of what room you're in, but we'll use the bottom left one for all intents and purposes. What normally happens in our hearts is blood will come into the room. It builds enough volume and enough pressure, causes our doors or our valve to open. Blood rushes out into the next room, volume falls, pressure falls, and the doors close. That's the same way all throughout the valves in our hearts. Now, when there's a problem with this valve, let's say you have a leaky valve. What does that mean? Same thing will happen. Blood will come into the room, builds enough volume and enough pressure, causes our doors to open. Volume will fall, pressure will fall as that blood shifts into the next room. But when it comes time to close those doors, they're only coming about this far. So you have blood that's leaving the room, but you have some blood that's coming back into the room just because those doors can't shut the way they should. So that's that leakiness in our heart that you'll hear, or that word regurgitation. Essentially, they all mean the same thing. When you have a tight valve or a stenotic valve, what normally happens, or what will happen in that case, is blood will come into the room, but it takes a lot of volume and a lot of pressure to be able to open those doors. And then the minute they open and that volume and pressure start to fall, they shut right back. So it's really hard for the heart to be able to move kind of oxygenated blood into the next room and eventually the entire body. In both of these conditions, kind of the first symptoms patients will start to notice is significant shortness of breath or increased fatigue. So that's usually what that means. So that leaky valve or doors aren't shutting the way they should, they're not closing the way they should, or a tight valve or stenotic valve, it's really hard to open those doors. Perfect. So the first trial I'll talk about is called the Align-AR trial, and that's for patients who have a leaky aortic valve. And we have this valve here as well. We'll show it here. It kind of looks like a crown. It's a little bit like a crown, and that's actually the logo they use. Like I said, this device is made for patients who have a leaky aortic valve. So right now, kind of standard of care options for a person who has aortic regurgitation or aortic leakiness is being controlled with medications or having open heart surgery. Right now, really, there isn't another option for patients who go see a surgeon and the surgeon says, you know what, if I had to do surgery on you, I don't feel so comfortable we'd have a good outcome. For those patients right now, there really isn't anything else that can be offered to them outside of a clinical trial and outside of just staying on their medications. And one thing I'll note that I didn't mention before, all the procedures I talk about today are minimally invasive, which means they'll be done either through an incision in the groin or in the neck for one of those. So nothing that would have to open your chest up for these. So for those patients who see a surgeon and the surgeon says, you know what, wouldn't feel so comfortable doing surgery on you. They're on their optimal medications, but when we go do those ultrasounds of the heart from the outside, there's still significant leakiness in that aortic valve. They usually get referred to us for a study called ALIGN-AR, which is study design. It's a prospective single arm, meaning everyone who qualifies for the study gets the device, gets the valve, multi-center study to evaluate the safety and effectiveness of the JenaValve system, which is this device. The procedure itself, it's a transcatheter aortic valve replacement procedure, so a TAVR procedure. So it's something that you may have heard before. Sometimes patients will come into my office and they'll say, you know, my friend just had a TAVR done. Why do I have to go through research? She didn't have to. And the reason for that there is a commercially available and FDA approved, actually multiple FDA approved valves for TAVR procedures, but to treat patients with tightness in their aortic valve. So aortic stenosis, so the opposite problem of what this device treats in this patient population. So I always like to note that difference there. And the patient population, again, high surgical risk with symptomatic aortic regurgitation. And then there's some specific measurements here that we look at. Primary endpoints the study is looking at is all-cause death, all stroke, life-threatening or major bleeding, acute kidney injury stage 2 or greater, and major vascular complications, permanent pacemaker, and moderate or greater aortic regurgitation after the procedure. Study enrollment, it's 30 sites, and it says here 80 subjects every 6 months. The reason for that is that actually, that trial is at the very tail end. It's at the end stages. We actually expect FDA approval hopefully within the coming months. This device should be commercially available to all patients to hopefully get treated without having to see me. I'd love to have you all in my office, but I would love for patients to have a quicker way to receive this therapy. So that's why it's there. So hopefully you hear it in the news in the coming months, JenaValve. You'll remember it was this device right here. We also have it on here as well. Perfect. Next, we're going to switch from a leaky aortic valve to a tight aortic valve. This trial is the ENVISION trial, and the study design is a prospective, randomized, 1-to-1, multi-center of study evaluating the safety and effectiveness of the Navitor TAVI or TAVR system for treating patients with symptomatic severe native aortic stenosis. So we have a picture of what that Navitor valve looks like here. And this Navitor valve has actually already been FDA approved for patients who, similarly to ALIGN-AR, were high risk for open heart surgery. Patients who couldn't have open heart surgery, this valve has already been approved and is available on the market. But they're trying to expand their indication, say, hey, if this valve works for patients who are high risk for open heart surgery, why wouldn't it work for a patient who a surgeon sees and the surgeon says, you know what, if I had to do surgery, I think you'd do well. I think it'd be a successful procedure. So the patient population for this study is patients who are considered intermediate or low risk for surgical mortality. So they're just trying to create more devices available for patients who could potentially have open heart surgery, but don't necessarily want to follow that route. And it's randomized 1-to-1 because other valves that are commercially available have run this study before. They've completed their first phase of the study for high-risk patients, FDA approved, wanted to expand their indication, ran their intermediate or low-risk trial, and have completed that data, submitted all that data, and received the FDA approval. So this study randomizes between 50% of patients will receive the Navitor valve that company Abbott makes, and 50% of patients will receive what's a commercially approved valve for patients in that risk cohort, in the intermediate or low risk. Primary endpoints: composite all-cause mortality or all stroke at 12 months post-procedure. And study enrollment, there is 150 sites participating, and they're looking to enroll 1,532 subjects. Now, this study actually gets 2 slides because it's kind of running 2 studies simultaneously. It's also doing their valve-in-valve cohort. So I've talked about the aortic valve replacement, which is that TAVR procedure. Now, these valves, whether surgical or transcatheter, minimally invasive, sometimes they can fail. They have a certain lifetime. After several years have gone by, you could potentially, when you go do that ultrasound of the heart, see some tightness on there again, some calcium deposits. So, and we might say, you know what, I think you need another one. You need a new valve. So that is a valve-in-valve procedure where, that valve you have stays in there, doesn't go anywhere, but just procedurally, they put another one in between it. And they're trying to expand their indication for this valve as well. So testing it in a smaller number of patients, but also wanting to see, if it could potentially work and how those results are. So the study design is a prospective, multi-center, 2-group registry evaluating the safety and effectiveness of the Navitor TAVR system, or TAVR, in patients with a failing surgical or transcatheter bioprosthetic valve due to stenosis. So whether patients had it replaced the first time through open heart surgery, or whether they had it replaced the first time through the groin, minimally invasive. So this valve is looking to treat both cohorts, both types of patients. Again, patient population, this one is high or greater risk for open heart surgery with a failing surgical or transcatheter bioprosthetic aortic valve due to stenosis, insufficiency or leakiness, or mixed etiology. And the primary endpoints are composite all-cause mortality or all stroke at 12 months post-procedure. And again, it's 115 sites, so the same hospitals running the first trial are running this cohort of the trial, and they're looking to enroll a total of 250 subjects. So 125 in patients who've previously had a surgical aortic valve replacement, and 125 in patients who've had a transcatheter or to the groin aortic valve replacement. And that's actually a picture of the team here. We did our first Envision case here at TMC just earlier this year in January.
What are the failure rates? You're talking about a lot of people that have gotten this, but you don't ever mention the failure rates of these procedures.
So you mean overall what the endpoints are looking at? So that data becomes available every certain time period once the analysis, it'll have, let's say at a 3-year point, all that data is analyzed by the FDA. And then they create a report and they submit it, and that becomes available to us at conferences. So I can't tell you exactly right now that exact number, but for example, for that valve-in-valve cohort, where I talk about a previous treatment that had failed, so usually sometimes these transcatheter approaches, we say those valves have a life of about 8 to 10 years, 8 to 12 years. That's the average kind of lifespan of how long that valve will last before trying to requiring a new one in. But that's really why these trials, are so important, and why we follow patients for such a long time. Because we don't just put a valve in you and then, see you at 1 month and send you home. We keep following you sometimes for 5 years, for 10 years, because that data is really important to collect. And we want to make sure that all those devices that do become available one day are the right treatment options. Does that answer your question?
No. I wonder how many people don't make it off the table or make it for a week or...
And that varies just depending kind of on industry. I can tell you our Envision case is very successful, but I can tell you it depends on the trial, it depends on the device, and depends on the patient as well. We have Restore, which is a study being run by Medtronic, which is a company that makes this valve that's here. And again, they're looking similarly to the Envision valve-in-valve cohort. They're looking at that same population, but this is a prospective, non-randomized, multi-center, post-market study evaluating outcomes of subjects treated with the Evolut, CoreValve, or a Sapien TAVR. So post-market, these devices have already been FDA approved to treat patients who've had a previous intervention or a previous procedure on their aortic valve. However, we're just looking to generate more data, follow those outcomes, see how patients do in the long term, just because it's not something super common. So we're just looking to create more data to have those numbers, to be able to share them with the public. Patient population, subjects with symptomatic heart disease due to bioprosthetic valves with bioprosthetic valve failure requiring a redo TAVR, a redo procedure. Primary endpoint, 30-day redo TAVR success. and 1 year freedom from all-cause mortality, all stroke, or any rehospitalizations for valve or redo TAVR procedure-related causes. And study enrollment is 100 sites, and they're looking to enroll 225 subjects. Perfect. Now we're going to shift away from the aortic valve space and go into the mitral valve space. So that's that valve that connects the top left room of the heart to the bottom left room. And this is the Atlas pivotal trial. And this is this valve we have right here, which I think is a beautiful model. It's wooden, it's hand painted, it's really, really nice. And this is that valve itself. This looks like a hot air balloon, like a cage. It's a little bit bigger than the Jena valve that I showed you earlier. And this study deals for patients who have leaky mitral valves, so much aortic talk. And the study design is a prospective single arm, meaning everyone gets a device if they're eligible for it, multi-center study to evaluate the safety and effectiveness of the Alta valve system. And that's, I also have it right here. It kind of looks, like I said, like a hot air balloon. And the patient population are subjects with moderate to severe or greater mitral regurgitation and or moderate to severe mitral annular calcification. So sometimes patients in the mitral valve can start to develop calcium. Not super common like the aortic valve. It's a little bit more rare, but it does happen. And this valve has the capacity to be able to treat both the leakiness and that calcification if it does develop. We have primary endpoints here are composite all-cause mortality or heart failure hospitalizations through 12 months. And the study enrollment goals are 60 sites, and we're looking to enroll 450 subjects. So again, right now, kind of available. If I had given this talk in November or before December 22nd, I would have told you that other than your medications and repair options, if you needed a valve replacement, really open heart surgery was the only option for mitral valve replacement. As of late December, there's a valve that became FDA approved, which we were also part of that trial earlier on in its earlier stages. So it's very exciting. Now I can tell patients, you know what, if this doesn't work out, if one of the trials we have for you isn't an option, there's something out there that could potentially be an option. But again, why it's important to keep running these trials, just because we don't, that valve also has certain anatomical exclusions. So it's really important that if that isn't an option for patients, there's something else that continues to be studied, continues to be tested to show, hopefully one day, that it's effective and safe for patients, that it'll be FDA approved again. Perfect. I have the High-Life EFS study. And EFS, what that means, those three little letters, means early feasibility study. So that's kind of its earlier initial areas of testing. So there's always, for anything that's kind of available out there, it's tested in a lab, tested in animals. They're their first in-human study, which literally means the first patient in the world to be treated with this device. And then after that, there's a couple patients who are in there. Early feasibility, a little bit larger number of patients, and then pivotal, which is kind of that final stage of testing. So this is High-Life, and it's early feasibility study in its early feasibility stage. However, it does have FDA approval already, and we expect the pivotal study, that final stage of testing before full FDA approval, hopefully, to start within the coming months as well. And this study design is a prospective, single-arm, multi-center study evaluating the feasibility, safety, and performance of the High-Life transseptal mitral valve replacement system. And you can see it on here. It looks a little bit like a math equation, a math problem. It's a two-part system. So this one, that first circle you see on there, it looks like a little bit like a ring, and I like to think of it as a new door frame. So we give you a new door frame, and then that second part of it is the valve that sits in between that door frame. So it's a two-part system here, which makes it a little bit unique and a little bit different to everything else I talked about. Patient population, symptomatic, moderate to severe, or greater mitral regurgitation despite GDMT. So patients who have that leaky mitral valve, again, just like the Atlas study, patients who have that leaky mitral valve despite being on their best medications possible. Primary endpoints, technical success, defined as an alive patient at an exit from procedure room. With all the following, there was a long list there that didn't show up here of complications. Study enrollment goals, 15 sites and 50 subjects globally. And again, this is another picture of the team here. I was the first High-Life case done here in Arizona. It was at TMC Health, and it was actually the first hospital in the Southwest to offer this as an option. That was back in 2023. And then another picture here that for TMC Health, but they became the first in human to be treated with that large annular size. So that larger size of that valve, the first patient was actually treated here at TMC from the entire world, also in 2023. So big year for High Life here. Now we have mitral 2, again, the mitral valve space, but a little bit different. This is looking again at patients who just developed that very kind of thickening of very, very coarse calcification around their door frame. So get calcium deposits, similar like I mentioned with the Atlas trial, that study that also dealt a little bit with the mitral calcification, Same thing with this device. This study is a prospective, multi-cohort, multi-center study to assess the safety and efficacy of the Edwards Sapien, Sapien 3 Ultra, Sapien 3 Ursilia, all iterations of the same valve. So actually, this is interesting because this valve, this one right here, it's the Edwards Sapien valve, and this is actually FDA approved to treat patients with aortic stenosis. So patients who have a tight aortic valve, this is the valve that can be used to treat them. Now, because it treats aortic stenosis, aortic tightness with that calcium, there's a study being run, this study by Mayo Clinic, saying, what would happen if we use it to treat patients with that same degree of calcification on the mitral valve? So that's why this study is being done, and this is the valve that's being used. So the patient population is high surgical risk participants with symptomatic severe mitral annular calcification who also have some degree of significant mitral valve dysfunction, whether that be complete stenosis, where it's very tight, where there's leakiness, or whether there's a little bit of a mix of both. So it does require a lot of calcium to be able to fixate, because that calcium in our heart kind of works like Gorilla Glue, helps these valves stay in place, whether it's in the aortic space or in the mitral space. Primary endpoint is composite all-cause mortality and heart failure hospitalizations at 1 year. And the study enrollment is 25 sites, and they're looking to enroll 210 subjects. It's also very close to finishing up. Next, we're going to move a little bit, still kind of in the mitral space, but also with patients who have a very well-documented history of heart failure. So all these trials that I mentioned before were moderate to severe leakiness in the aortic valve or some type of stenosis. So this one is some degree of leakiness in the aortic valve, but also with a documented history of heart failure. So the study design is a prospective, randomized, 1-to-1, blinded. So it's the first time we're seeing this today in our presentation today. Multi-center study to evaluate the safety and efficacy of the Carilion mitral contour system in heart failure with functional mitral regurgitation. So the patient population is symptomatic heart failure with functional mitral regurgitation, and then some very specific measurements of the heart. The only thing that isn't kind of a requirement, you don't have to have that moderate to severe leakiness in the aortic valve to be a candidate for this. Really, it's kind of very specific measurements that are done based on imaging. All patients will have some sort of imaging prior to a procedure. So the company looks at those measurements very well to see if they're a good fit for this device. And actually have the model here, and I'll put up the picture on here. So this is what it looks like. It's a little bit harder to see, but essentially it sits in a part of our heart called the coronary sinus. This is what it looks like, and it sits it'll live kind of like this on its side in that part. And the idea of this device is that as it goes in, it'll eventually help kind of remodel and restore the function of our heart to allow our heart to pump a little bit better. Reduce, if it's a big valve, help reduce that size to then hopefully kind of increase compliance with it. The primary endpoints, what they're really looking at is demonstrate freedom from a composite of pre-specified adverse events in the intervention group at 1 year is greater than the performance goal at 90%. And looking to enroll 75 sites and 300 subjects. So that's for patients, what I said, reduced ejection fraction, which essentially is how much blood our heart pumps out to the aorta and our entire body, as well as some degree of leakiness in the mitral valve. Next, we have core cinch. It's also for patients that have a documented history of heart failure. So it's a prospective, randomized, 1-to-1, multi-center study to evaluate the safety and efficacy of the AccuCinch ventricular restoration system. And that's this device we have right here. And then the way it works, it'll normally, once you kind of pull on this, it cinches. So it looks like it wraps up kind of like one of those bracelets that were in fashion a while back where you can kind of slap it and it'll wrap around your wrist. So kind of like that, it kind of curls up. And the way this lives in our heart is that you guys can come up at the end of it and see it a little bit closer, but it does have kind of these, what they look kind of like staples and sliders. And these will be put into the heart wall, into our muscular tissue. And at the end of the procedure, they will cinch it, kind of like a coin purse that you'll cinch together, hence the name core cinch, and this is the AccuCinch device. Cinch it together with, again, the hopes of reducing that degree of hypertrophy or that degree of enlargement in the heart over time to help it pump more effectively. Because when we have heart failure for a long time, sometimes this room in our heart, the bottom left room specifically where this device sits, can get enlarged over time. So the goal is, and because if it's enlarged, it can't pump as much blood out. It loses a little bit of its compliance and contractility. So the goal is to hopefully reduce and remodel that bottom left room of the heart. So again, the patient population, it's symptomatic heart failure with reduced ejection fraction despite optimal medical therapy. And again, some of those dimensions of the left ventricle, those measurements that we make on imaging, and history of an aortic mitral valve that's leaky with a degree of mild or less. So this is different from all these other devices where we said it was moderate to severe. Similar to Empower, this one's looking to MR of mild or less. Primary endpoints are related adverse events and quality of life, with the quality of life questionnaire and 6-minute walk test that we'll complete at 6 months and 12 months, and all-cause death, LVAD implant, left ventricular assist device implantation, heart transplant, and number of heart failure hospitalizations at 12 months. Study enrollment is at 80 sites, and they're looking to enroll 400 subjects. One thing that's important to note, these are all, specifically this device, it's meant to bridge the gap to provide some relief right now, but a lot of the times these patients ultimately do require some type of heart transplant or left ventricular assist device implantation. So it's looking just to bridge that gap from right this moment into the future. And you'll see it on here. That bottom picture is kind of looking at it from the bottom, of where that would be sitting in the heart wall. That room you see on top is the mitral valve. And then this is how it looks kind of on the side. Perfect. So we have another one of those pictures here. This is the first AccuCinch implant in Arizona, also happened here at TMC in Tucson, and became actually the only hospital in the Southwest to offer this option. That was also back in 2023. Next, we have the Laplace EFS, so we're moving away from the mitral space into the tricuspid space. So right now, this one deals with a leaky tricuspid valve. So the study design is it's a prospective, single-arm, multi-center study looking to evaluate the safety and effectiveness and technical feasibility of the Laplace transcatheter tricuspid valve replacement system. The patient population, symptomatic, severe tricuspid regurgitation despite GDMT. So patients, when we go do that ultrasound of the heart, despite being on the best medication for them, we still see significant leakiness at the heart. And for everything else I kind of mentioned, it goes through the groin. For this one, initial stages, they went just through the neck, so just through the jugular vein. This is where it started. Now, recently, they've done their first couple of cases through the groin as well. So now for patients who might not have good access through the vein, through the groin is another option now. Primary endpoint is freedom from device-related major adverse events through 30 days, need for reintervention for regurgitation, as well as technical, procedural, and device success. And the goal is study enrollment goals are 20 sites, and they're looking to enroll 45 subjects. And they've actually just received approval as well to start their pivotal phase. So that next stage of testing. This was the early feasibility, small number of patients, and very early on to their pivotal. So a larger number of patients. And then we have that picture of what the valve looks like as well. Perfect. And that's actually something very exciting to us. Actually, when I first applied to this program, this is one of the things that drew me to it, what I had heard. TMC did the first in-human Laplace case here in 2024. So the first patient ever in the world to be treated with this device happened here at TMC. So that's something that was very exciting. So that's a big picture, big group of people there that, made everything possible. So it's something pretty huge. Normally these procedures happen elsewhere or in another country. So there was something very exciting for it to happen here at TMC and in Tucson. Perfect. So that's a list of all the active trials we have going on, currently enrolling. I also like to mention the list of upcoming studies, what to expect, what next. So we have for aortic stenosis, the STAR pivotal trial, which is for patients who have aortic stenosis again. But the difference, what makes this trial very unique is that the catheter that's used, so really what guides the procedure, what holds the device before putting it in your heart, is much smaller than what's commercially available. So for patients who might not have good access, who have smaller vessels, this will be a great alternative. Aortic regurgitation, ARTIST, same valve as the Jena valve that I mentioned in that study, Align AR, but this is for that intermediate risk of open heart surgery. So for patients who could potentially have open heart surgery, who the surgeon would feel comfortable doing surgery on for a leaky aortic valve, this will be a randomized clinical trial. So 50% of patients will receive the Jena valve device, minimally invasive, and 50% of patients would undergo open heart surgery. Cerebral embolic protection devices. So during those TAVR procedures, we mentioned that there's a lot of calcium on there sometimes. So there's always a risk, a little bit of a risk of having a stroke during that procedure, the risk that those pieces of calcium can get dislodged. So companies have developed some type of protection devices for the brain that kind of cover the arteries. They said the aorta is like the freeway, and the first exits of the aorta go straight to the brain. So these devices help reduce the risk of strokes happening. Yep, M-block coming up and ARC-CAF. New to us, a heart failure. This is actually something you didn't hear about today. Hopefully next year, if I give this talk, you'll hear me talk a little bit more about it, which is a drug trial. So a drug for patients who have been diagnosed with heart failure, run by Novo Nordisk. So we're very excited about that. We have mitral regurgitation. So like I said, highlights that pivotal study I was mentioning you. For patients with recurrent pericarditis, this is another drug trial. So I'll have some trouble remembering those names. They're a little bit more complicated than our device trials, but that's up and coming as well. And for patients with a leaky tricuspid valve, we have the TRICAV and Vista system, so tric valve and V-dyne. So hopefully those are up and coming. And like we said, we keep running these trials to have more alternatives for our patients. Perfect. Then, quick note, I'll mention our other affiliated programs. So we have the Advanced Degree in Engineering Clinical Research Fellowship that I mentioned earlier, the Postdoctoral Cardiovascular Clinical Research Fellowship, the Compassionate and Accessible Research Program, CARE, and then we also take part with the TMC Health Medical Education Programs, graduate projects, and research rotations. That's also a very nice part where our residents or medical students can rotate with us and have their research rotation and learn a little bit about that as well. Perfect. So this is a small kind of story on the Postdoctoral Cardiovascular Clinical Research Fellowship, which started in 2020. That's a program that's how I came into this program, through this fellowship. So it's really great exposure to the newest up and coming devices and learning, kind of what goes on behind the scenes from getting something commercially available. The Advanced Degree in Engineering Clinical Research Fellowship. So that was just established in 2024. Last year, we had our first graduate this past December. So it's very exciting to, like I said, all these devices are developed by engineers. So it's great to have their input and great for them to see the other side of things too, how these trials are run. We have the CARE program, so Compassionate and Accessible Research Program. Essentially, sometimes it's something that we're very proud of. And it looks, sometimes, patients may have something that we don't have a trial for. We don't have a device. We don't have the tools available right now within our established kind of research program to offer that to patients. So it's something we look into, or sometimes, patients might be excluded from a trial based on things, yes, maybe because they can't walk 100 meters in 6 minutes. Possible, and we know we have a device that would work, but because of this, the company won't allow them to take part in the trial. So for those patients who we either don't have an option and we try to do a little bit more digging for, investigate, what's out there, or for patients who we know we have something already that will work, but they can't take part of research for some reason, we go to the FDA and we say, you know what, we think it'd be compassionate for you to allow us to treat these patients with the device that I know will work, the device that I know will help them. Will you allow us to do that? So it's a lot of back and forth, a lot of work that our director does, a lot of work behind the scenes to make that happen. But we love to have this program to hopefully, offer patients an alternative, some type of treatment option. Perfect. So that was it for me. We have Natalia here, our Director of Clinical Research, myself, our address on here, as well as if you Google TMC AC Clinical Research, that's what will pop up on here, as well as our website that has all of information, all our contact details, all the studies we have, and how you can also get in touch with us if you're wondering about any of this. And I have this wonderful QR code. You guys all have it in your little pamphlet too. So if you scan it, that takes you right to our website as well.
Thank you so much. I've got a couple of questions that came in. Now, first of all, your office is just across the street. Let's just clarify that for everybody so that they know, right? Right across the street from the hospital.
Yes, so on the south side of Grant, next to outpatient therapy.
Okay. So a couple of questions for you. How long does it take from applying to be part of a trial to the actual procedure? What does that normally look like if somebody was interested in doing a trial?
Yeah, that's a great question. So that usually depends. It can vary depending from study, depending on what they are. I always tell my patients, I'm upfront. I could tell you you'd get treated in a week, but I know that realistically that's not going to happen. So depending on what device and what trial it is, I do say an average of about 2 to 3 months. Just because there are a lot of things, a lot of people that look at their imaging too. They look at their medical history to make sure they're the right patients and the right outcome. So about 2 to 3 months.
Okay. Are there certain medications that may disqualify you from a clinical trial? For example, maybe if you're on statins or a GLP-1?
No, not really. That all gets documented right now. The trials we have don't really exclude you from anything. Sometimes if you can't tolerate certain medications, that's more potentially of where, a trial could potentially exclude you. But as of right now, those statins that you mentioned or GLP-1, those are an exclusion for trials that we have at the moment.
Okay. Now, Dr. Olivares, if somebody is interested, they've watched today and they're interested in learning more about a particular trial, what are those steps? How does this all happen? I know you have the scan, you have the code and whatnot, but can you just sort of walk us through what that process looks like?
Yeah, that's a great question. So we always recommend, first and foremost, establishing with the cardiologist, going to your primary care physician, and whether there's a concern or not, saying, you know what, I'd like to establish care with the cardiologist, just, yearly checkup, make sure everything looks good. And from there, we work very closely with a lot of the cardiologists kind of in town. A lot of them know about our program. So whether it be Pima Heart or any of the other cardiology groups in town, they're very familiar with what we have. So I always recommend establishing care with the primary cardiologist, checkup, and if there's anything of concern for any of the trials we mentioned, any of the diseases, they're very good at referring you to kind of our investigators who then get you referred over to us. But of course, you have that information on there. You can contact us directly, but establishing with your primary cardiologist is really important just to make sure, we do what's right for you and get you treated with the right device or procedure potentially.
And if somebody has a question regarding any of those trials that you just mentioned, are they able to reach out to your office or maybe they're not sure, but they want, there's a lot of information, of course, that goes into each of those studies. And so what does that look like?
Yeah, no, definitely. They can definitely reach out to my office, and then we'll have our assistants kind of set up a phone appointment with me so that we can talk on the phone, go over any questions you have, any concerns, and we can hopefully point you in the right direction from there.
Okay, great. Thank you. Well, that wraps up all the questions that I had, Dr. Olivares. I'm going to go ahead and wrap up with our online audience, and I will turn it over to you for any questions in person. Thank you so much for being here. And I know you're coming back during our Heart Smart Expo. So that's another opportunity. If somebody wants to speak with you then, that's another great way to learn more.
Yes, definitely. Thank you so much.
Thank you. All right. Thanks again for being here today. We look forward to having you back. Next week, we've got 2 more wonderful talks that are all part of Heart Month. The first one is Rebuilding Strength, the Power of Cardiac Rehab. That'll be on Tuesday, February 10th at 11 a.m. The next talk is going to be Reducing Heart Risks, The prevention is key. That'll be on Wednesday, February 11th at 4 p.m. If you're interested in either of these classes, we still have space for you to attend in person. You are more than welcome to give us a call and we can help get you registered. The phone number is 520-324-1960. Thank you again. We hope to see you again soon.